I am Nidhi Bhatnagar. I'm an audiologist and speech language pathologist. I completed my master's in 2009 from PGI Chandigarh, and ever since I've been into private practice. I have my center by the name of Beamer Clinic in Mohali, and will be opening shortly in Chandigarh as well. So a very good evening. Thank you very much for taking out time this evening. And while we all enjoy our drinks, I just hope that we do take back some important information and learn at least one thing from the CME today. So first and foremost, I'd like to just take a head count of the entire gathering here. Of course, I recognize all the audiologists in this group. So let me ask, how many ENT surgeons and practicing otolaryngologists are present here? Can you please raise our hands? So we should raise it like at this level, you know. A neurologist would raise it like this, not like this. Alright. And what about pediatricians? Great, lovely. So my talk today will be a blend of information that would be, I'll try my best to be useful to both ENT surgeons as well as pediatricians. So when we talk about early identification and newborn hearing screening, we need to understand that hearing loss, the first person or the first doctor that a family needs or comes across when they have a baby is of course a pediatrician. So it becomes invariably important that a pediatrician is aware and oriented towards the possibility of having a hearing loss, especially high-risk babies. And the first person that they refer those babies for a hearing assessment would be an audiologist or an ENT person. So what we are going to talk about today is that if we are talking about cochlear implantation, we should know that what are the procedures for screening of a child who has a suspected hearing loss, and thereafter what are the possible ways and means of rehabilitation or habilitation in a young child. So, of course, hearing connects us to our world, to the small everyday wonders and to the people and experiences we love. So first and foremost, normally when we go to hear a talk or see a presentation, generally once the presentation is over, the speaker would ask you, I am happy to take any questions. I would rather prefer doing it in the reverse order because it's an obvious gathering. There is no point of me teaching you things about, things you already know. So I would like to know that what is it that you would like to learn or what to find out, or any doubts that you come across when you see a BERA report or an audiology report or a hearing assessment. So just make yourself easy, raise up your hand and let me know what is it that you are trying to learn from the hearing report side. Anybody? Nobody wants to learn anything?
After the talk.
After the talk, okay. But there is one question which I know that Dr. Sunil definitely wants to know, is that how do we decide OE करना है तो कौन सा करना है? DP करना है कि T करना है? DP करना है तो DP क्यों करना है? T करना है तो T क्यों करना है? That is what I like about him. He wants to know what is happening to the child, why we are doing a particular test if we are doing it, how will it be interpreted and how is it going to affect the life of the child. It's not only about कि आजकल इन है बेरा कराओ, बेरा कराओ, बेरा कराओ, बेरा कराओ. क्या उस बच्चे का बेरा होना चाहिए? Is बेरा really required for the child? Is OE the choice of test for an individual? So this is what we'll be trying to cover in our talk today. So universal newborn hearing screening, like Dr. Dheeraj has already discussed, most of the developed countries are following the universal newborn hearing screening as a mandate. Without fail, every child who is being born in a private setup, public setup, government-aided scheme, every individual baby has to be tested for his hearing thresholds. Unfortunately, in a country like ours, this is still not a mandate, but yes, now the scene is changing. More and more of people, whether in the government setup or in the private setup, are going for hearing screenings, understanding the importance of it. So I'd like to draw your attention to this consensus statement of the Indian Academy of Pediatrics on newborn hearing screening. This was published in 2017, which highlights certain very important points which is important for pediatricians as well as ENT surgeons to know that most often ENT people, ENT surgeons are blamed. कोई 3-4 टेस्ट हैं वही लिख देते हैं, वही 3-4 टेस्ट हैं वही लिख देते हैं. And sometimes it becomes rather embarrassing to understand that even other, specialized areas, if you go to a neurologist, of course he get an MRI done. Why would someone not question that? कि वही MRI है वही लिख देते हैं. So we need to know our facts, and these are the recommendations which are given in this report. That a 2-stage screening protocol with OE as a first screen followed by ABR. For those who fail the OE screen is advised, and all NICU babies undergo ABR testing to rule out auditory dyssynchrony or auditory neuropathy. So every child who requires a NICU stay, whether the affordability is there or not, we need to understand as pediatricians, as doctors who are seeing the child, that it is not always about how much the patient is paying. It is not only about the vaccination, the immunization and things like that. Of course, they have their own stand of importance. I am a mother, I understand that. But hearing, vision cannot be, I would say, underrated as far as the newborn hearing screenings are concerned. The key messages in this was that hearing loss should be screened preferably before 1 month of age. Universal neonatal screening rather than targeted high-risk screening is ideal. If abnormal OE is detected, it is repeated at 6 weeks or the first immunization when the child is visiting for the vaccination. And all NICU babies should undergo ABR testing to rule out ANSD. So we just discussed this. So screening protocol which is followed at my clinic. We do an inpatient screening with the OE. Normally it is a handheld OE, and if we get a refer in the first instant only, then we ask the patient to come and see us again after a period of 3 to 6 weeks for an OE or an APR. If the child passes and falls in the higher risk, then we screen again at 3 to 6 months with an automated APR or an OE. And if the child passes, we keep the child on an annual follow-up. And otherwise, if we get a refer, then we screen again at 3 to 6 weeks, pass, again the same protocol, and if the refer is there, then we go in for a diagnostic para, and thereby make a final diagnosis when we decide about what has to be done. So universal newborn hearing screening followed by an OE, ABR if required, and a VERA. So this is the portable OE instrument. It is a small handheld device which can be later on connected to a laptop, and a report can be generated which can be handed over to the patients. And it can be carried in a bag, which is easy. The OE testing can be done by the bedside in the room when the child is present with the mother, or even in NICU. So it's a portable device, very easy. This is the kind of report which is generated. We see that consecutive frequencies are there, and this is the test for the left ear, and it's showing the past result. Now these stimulus parameters which are there, often we get this question that audiologist भेजने की क्या जरूरत है? Nurse को train कर दो, nurse कर देगी. So had it been so simple, तो हम लोग 8 साल लगा के audiology की पढ़ाई नहीं करते. The stimulus parameters that are given here, they are specific to the kind of testing environment that we are testing the baby in. Is the test being carried out in the general ward? Is it being carried out in the NICU? Are they carrying it in the ENT OPD? Is it being carried out in a soundproof room? According to the testing situation, these stimulus parameters have to be changed, and only then can you get a reliable OE report. It is not that it's the same probe, same instrument which you are putting into all the ear canals coming in front of you, and then blaming the test कि ये तो हर एक का ही रेफर आ जाता है, हर किसी का ही रेफर आ रहा है, हर किसी का ही पास आ रहा है, ऐसे थोड़ी हो सकता है, करना नहीं आता. So this is what happens when an untrained person who's not qualified, who does not know the details of how the stimulus parameters have to be changed, will perform an OE test. So it is very important for you as ENT surgeons, as pediatricians to ask your audiologist or the person who is testing that have you taken into account if you are testing in a NICU or by the bedside, or are you carrying out the test in a noise-proof room. So accordingly, the parameters will change. Here you can see that we are doing it in the OPD, this is in the NICU, and this is by the mother's side. So of course, OE's advantages, it is cost effective, very quick to administer, minimal training is required, small and portable, and the disadvantages are higher likelihood of false deaffer because of the presence of fluid in the ear canal. We do often see that when we are testing immediately before discharge, we see a high rate of refer, and the OEs do not test beyond the cochlea. Since OE is a test of outer hair cell function, it will not give us information of the areas beyond the cochlea, that is the ear nerve or the higher brainstem regions. Now talking about the automated ABR, it is not so much in vogue in India so far, but a lot of private clinics and a lot of other setups are coming up with AABR. We have recently procured an AABR, and it is not as time consuming as a typical BERA, because a typical BERA involves sedation, it involves a longer duration of testing, the babies sometimes get up during the test, so there are limitations of a full diagnostic BERA, which this takes care of. A series of small sounds are presented at minimal levels, and special electrodes are placed like we do in a regular BERA, and the signals are amplified and information is given. Again, the resultant disc is given in the form of a refer or a pass. There is no diagnostic report which is obtained. Of course, auditory neuropathy in NICU patients cannot be found out through this instrument. So again, this is one instrument which has its own advantages. It is more robust than an OE. It is not affected by middle ear fluid, and it tests up to the level of the brainstem. Definitely more expensive, will be a little higher on the pocket. More training is required for patient preparation, and the testing time will be longer than it takes to test a OE for a child. Now comes the $1 million question, whether should we go for AABR or should we going for a OAE? So what we follow here, and which most of the clinics or most of the setups or government hospitals are following, is that the first test which is conducted is an OAE. Only if the baby comes to a record on the second stream itself, then only we going for a ABR or a AABR. So this is the diagnostic BERA. As we can see, it can be done during natural sleep and in the mother's lap also. So now we also have the facility of awake state BERA, where sedation is just not required. So this is a major advancement, because one of the major problems that we face during the recording of a BERA is that बच्चे को दवाई पिलाई, बच्चे ने दवाई निकाल दी, अब वेट इतना है, we can't give more dosage, the child cannot sleep, the parents have traveled from 6 AM in the morning, बच्चे को लाद के लेके आए जी बस में, आपके टेस्ट नहीं हो सकता, and all in all it's a vicious circle. So an awake state BERA minimizes the patient risk, it facilitates the early detection of hearing loss, significantly reduces loss to follow-up issues for newborn hearing screening programs. And here you can see this is a much older child, he's sitting on the bed, and of course they have to be given some form of reinforcement to sit in this particular way and get the BERA done. But slowly and gradually, even smaller population, when they are given a toy of interest and if they are explained the procedure that this is not going to be painful and you can get to play with this toy, or you're going to get a candy or a chocolate once you continue with the process, they very much cooperate to get an awake state BERA done as well. So when we get a BERA report, normally these are the 4 things that we talk about: an absolute latency of wave 5, interpeak latency between the different waves obtained, the morphology and reproducibility, and auditory neuropathy if present. Now often when we get reports from other centers, what we see is a BERA report which rather looks like a EEG report. It's got lots of peaks and valleys, and reminds you of Pahalgam and Kashmir. But nowhere, I often get phone calls from pediatricians and ENT people कि BERA report है, बाहर से आई है, इसको जरा interpret करके बताओ. And when I see the report, I call back and say, sir, इसको कोई interpret नहीं कर सकता. So we need to understand that if we are giving a diagnosis of a profound hearing loss, what are the parameters that we should identify in that report? If we are calling a particular BERA report as that of being that of a normal hearing child, we should be able to interpret the report. So this, what you see here is a BERA report of a child who's had normal hearing in both the ears. Of course, the right side is represented in red color and the left side is represented in blue color. You can see that we are testing it at different levels, 90, 70, 50, 40. And this is the peak 5, which is gradually the latency is increasing and the interpeak latency between all the peaks. This is what we look at. We look at the wave morphology and we see the inter-ear difference. If the sound is reaching from the right ear at a particular time till the level of the brainstem, it should be reaching the other side also in a particular margin frame of time. Here you can see the report of a child with a unilateral hearing loss where the right ear is showing a peak only at 99 decibel, whereas there is no proper wave at any other intensity. However, on the left side there is a significant wave 5. This is a moderate to severe loss on left side. And this is a profound no wave 5 can be seen. So now we need to understand, you might ask me that ye bhi to hai kuch. In the last report you had marked a peak. I can see a peak here. Why haven't you marked this? So you need to understand that it has to be reproduced several times. I often get the question कि 1 घंटा बेरा करते रहते हो, क्या करते हो बेरा में? Waves तो लेनी है. The point is, if I take one wave and I do not see whether it is reproducible or not, I cannot be sure whether the child has a hearing loss or has a moderate hearing loss or has a normal hearing. If I am not sure of my diagnosis, I will never be sure of the treatment. And when it comes to the age of the child, a young child who has his entire life in front of him, I wouldn't mind spending another extra 1 hour or repeating the BERA for that matter. And whenever we repeat a BERA to confirm the report, we do not charge as much. So this I want to reiterate. कि अगर 2 बार बेरा कराएं उसका मतलब ये नहीं है कि हम 2 बार फीस ले रहे हैं. कुछ लोग अच्छा काम genuinely करते हैं and they really want the right diagnosis. So once we have a confirmed diagnosis of a sensorineural hearing loss, then comes the major question. Now we know about cochlear implants. Cochlear implants is the in thing. Dr. Dheeraj is doing cochlear implants. Let's send this child for implantation. और सुबह से 10 ऑडियोलॉजिस्ट या 10 हियरिंग एड सेंटर्स के लोग आ चुके हैं. 6 कार्ड मेरी टेबल पे पड़े हैं. बहुत देर हो गई, सर्जरी का मूड नहीं है, भेज दो हियरिंग एड के लिए. This is not the criteria of deciding whether we need to go for a hearing aid or a cochlear implant. As professionals, as doctors, we need to be very sure that in which cases a hearing aid will work and in which cases a cochlear implant will work. You cannot afford to wear sunglasses when it's raining. I mean, an insane person would do that. Nobody stops you from doing that. But that's not the right thing to do. So we need to understand that why do audiologists recommend a complex hearing device which involves a surgery over an easy to fit hearing aid? A lot of patients, a lot of parents for that matter, whom we counsel for a cochlear implant, ask us कि बाकी के बच्चे भी तो घूम रहे हैं यहाँ पे, इनको तो आपने मशीन लगा दी, हमारे बच्चे को कह रहे हो 15 लाख का इम्प्लांट कराओ, क्यों? So when we are dealing with the patients or the parents' remorse of understanding that my child is born with a hearing loss, we also have to deal with such silly questions. So we need to understand that when we are talking about a hearing aid, the hearing aid is picking up the sound and that amplified sound is reaching the outer ear, the middle ear and the inner ear. Once it reaches the inner ear, from there, if the inner ear cells are not present, the transmission, the conversion of energy from one form to the other will not take place. If the inner ear cells are not there, the sound energy will not get converted into electrical energy and will not be passed on to the auditory nerve. So even if you're wearing a 10,000 ka hearing aid or a 1.5 lakh ka hearing aid, it does not matter. because the sound will not travel further. If the sound does not reach the auditory nerve, it will not reach the brain, you will not see a response. So often we get parents who tell us, आपने बाहर जो बच्चा घूम रहा है उन्होंने बताया कि इसके 2 लाख के हेयरिंग एड लगे थे दोनों कान के, अगर हम लगा देंगे 2 लाख हम लगा सकते हैं पर हम 15 नहीं लगा सकते. And believe me, there are those parents who've come and we can see that they've got down of a BMW or an Audi. तो अगर वो एक ऑडी में आ सकते हैं टेस्ट कराने के लिए, तो क्या वो अपने बच्चे के लिए इतना स्पेंड नहीं कर सकते? इट इज जस्ट दैट दे नीड द राइट काउंसलिंग. इट्स नॉट अबाउट 2 लाख 15 लाख, इट इज अबाउट व्हाट इज राइट फॉर देयर चाइल्ड. एंड इफ यू एजुकेट देम इन द राइट मैनर, then they do take the right decisions. We have a lot of cases who are going in for simultaneous binaural implants only because they've been counseled in the right fashion. So what is a cochlear implant? A cochlear implant is a surgically implanted neuroprosthetic device to provide a person with moderate to profound sensorineural hearing loss a modified sense of sound. It bypasses the normal acoustic hearing process to replace it with electric signals which will directly stimulate the auditory nerve. So if the inner ear cells are not present and we are stimulating the auditory nerve directly, that is how the areas in the auditory cortex will start responding to sound. So it is very important for us to take 2 minutes out, draw a simple diagram on a page and explain it to the patient in basic simple language. कि यहाँ से यहाँ पे ट्रांसफर नहीं हो रहा, मेडिकल साइंस जादू नहीं है, इसका इलाज ये है, इसका इलाज ये है. Unfortunately इस इलाज का इतना कॉस्ट है. If the right information is given and we have to give the patient the time to absorb that information, we need to give them the right source of material to read about it. Thankfully, आजकल Google is good at everything, right from telling you what is the temperature outside to what is going on in real estate. Google has affected everybody and everything. But we need to tell our parents that if you want to read about it, if you want information, we will provide you with the information, but go to the right source. This is the leaflet, this is the pamphlet. इसमें से पढ़ो, इसको समझो. अगर और समझना चाहते हो, if you need information, we will give you more information, but you should have the right source. So, pediatric cochlear implant candidacy is a complex process. Of course, it involves a team of professionals and the family. And it has to be multidimensional, which has to take into account the family support, the finances involved, and surgery, like Dr. Dheeraj discussed, it is 25% of the process. The remaining 75% all depends upon the rehabilitation, the audiologist, speech therapists who are working, and one major role is played by the parents. Because the surgery is done, the child will only be seeing the therapist for 1 hour in a day. The remaining 13-14 hours when the child is awake, that is the entire duration where the parents have to work with the child. So we need to give them realistic expectations, and appropriate supports have to be given in actual benefit has to be derived. So the process of getting an implant, initial referral, medical evaluation, audiological evaluation, we of course going for a period of 3 months of hearing aid trial for the patient, because some patients insist that नहीं, एक बार हम मशीन लगा के देखना चाहते हैं. We should give them that. We should wait for that period of 3 months. Earlier, this duration was much longer. People would wait for 6 months of hearing aid trial, but now it has close to 3 months and also around 6 weeks at some centers. And once we see no progress and the parents have worked hard enough with the child and they've realized कि चाहे जो मर्जी hearing aid लगा लो, the child is not listening, and then you introduce them to other families who got their children implanted and are doing so well, then it becomes much easier to get the CI surgery for them. Post-surgery is the activation process. This is where the audiologist steps in after the initial diagnostic part. It's a unique, unforgettable experience. Not all switch-ons are happy. There are switch-ons where the child cries the heart out, but even that is a response. So that also has to be explained to the parent. Someone who spent 15 lakhs of rupees wouldn't want to take their child howling and crying. So we inform them in advance कि ये भी रिएक्शन है. हो सकता है बच्चा खुश हो सकता है बच्चा हैरान हो जाए, हो सकता है बच्चा रो पड़े. तो अगर बच्चा रोए मतलब उसको सुना. So you have to be happy. So if the बच्चा starts crying, the parents are happy. रोया, इसको सुना. So you need to think about all these things. 2 to 4 weeks post-operative, it varies from one center to the other, and the comfort is the main goal. That the child should be comfortable with the device. He should start getting ready to wear the device. There should be no fear in the child's mind that this might give, because there are parents, there are mothers who, while getting the second or the younger child implanted, they're counseling the elder one. इसमें से करंट लग जाएगा, इसको फेंकना नहीं है, इसको हाथ नहीं लगाना. So if you're scaring of one sibling कि इसमें से करंट लग जाएगा, you're automatically scaring of the younger one कि पता नहीं क्या है, इसमें से क्या निकलने वाला है. So no fears of this, and you have to be very careful as far as children are concerned. Mapping, fine-tuning the device is an ongoing process. It requires specialized software and programming interface, which thankfully all the cochlear implant manufacturing companies provide to the audiologists. I would especially like to mention Manraj here because he was great support as far as the post-op mapping and things are concerned. Then listening training or the auditory verbal therapy, which is a specialized program which is taken care of especially in children who have been implanted, even with adults. An individual program is worked out for each recipient. No two children or no two adults with a cochlear implant will have the same rehabilitation program. So you need to understand that if child A is taking a particular route towards his journey towards hearing, another child will not have the same program because the family support will vary, the educational background will vary, the resources will vary, the frequency of their visit to the clinic will vary. So a lot of things change. The focus is of course on listening. We try to avoid lip reading and visual stimulus as much as possible. Only where the children needs some special kind of attention. If we have children with multiple disabilities, their lip reading and total communication are encouraged. But otherwise, children follow the training protocol like we would deal with a normal hearing individual. The parent is trained to carry over listening training at home in a natural setting. They have to be our partners. Here you can see a mother actively engaged during the therapy process, and we make sure that the parent sits inside. There are a lot of centers which make the child take therapy while the parent is out shopping. मैं बिल जमा करा के आता हूँ, 1 घंटे बाद पिक कर लूँगा. This is not how rehabilitation works. Until you know what is being done and what needs to be replicated at home, there is no point of that therapy. So parents have to be active partners. Cochlear implants provide hope for children with hearing loss and their families. The right solution will help them to enjoy a life full of sound, speech, laughter and music. And every children born profoundly deaf can learn with confidence at a mainstream school, dance along to their favorite song, and hear you tell them that you love them. We've had a wonderful journey so far. These are most of our children who are implanted and are doing very well. And this little fellow here, it's his birthday today, Rajana. And so yes, we are very proud that we take our due course of time as far as the diagnosis is concerned. We make sure that the surgical procedure, the surgeon, Dr. Cochlear, is taking care of all, if the correct information is provided to the parents beforehand, that this is the kind of outcome we are expecting, then the results automatically, it is a teamwork. No one single team member will be able to carry on the show individually. This is my team. Love you girls. And I am open to questions now or even while we are having dinner. Thank you very much for listening and for preferring to listen to me over your mobile phones. Thank you so much.
AVR is primarily like screening bearer.
Yes, it's a screening bearer. In that there is a fixed intensity level
and it will take roughly around 14 to 15 minutes to complete the para. So if we are doing a child who has a referred OE at 2 consecutive attempts, then we prefer to go in for a diagnostic para. But sometimes it so happens that however hard we have tried, but the child is not sleeping, or we are not able to get to do an awake state para, then AABR at least gives us some idea, and we tell the parents about auditory monitoring at home. So that really helps. So it's just another tool in our armamentarium of tests that we have. So it's always a test battery approach. So it takes lesser time, but then you cannot, especially in NICU babies, I will not advise to go in for an AABR. For NICU babies,